you. I wanted to also thank Mainliners and Ian for helping out. It's been interesting for me to be here just to hear different perspectives from around the world, so it's been enlightening. I'm going to talk about psychiatric and substance use disorders and their effect on the care of patients with hepatitis C. As my background is mostly working in the VA system, which is an integrated care system within the United States, taking care of veterans from World War II to the current returnees. So it's a little bit of a narrow perspective. But actually the VA has been pretty proactive in trying to address hepatitis C. There was a mandate for screening and testing all people who were at risk in the VA system. And there's actually a clinical case registry which encompasses all the patients who actually have hepatitis C in the system, mostly for the purposes of improving and helping clinical care. And I'll be presenting some of the data that comes from this clinical case registry. So I just wanted to preface that. I hope to cover, obviously, that psychiatric and substance use problems are common among hepatitis C patients. There is a combination of patient, clinician, and systemic factors that create barriers to care. I think you've heard of some of them at a little bit different level than where I will be talking about. But there's been a concern that psychiatric and substance use disorders impact adherence to antiviral treatment. And I'll hopefully talk a little bit about that. And if I have time, I'll at least briefly touch on a similar approach to what Helene Williams talked about, what we've done at our VA, and trying to come up with some solutions to hopefully eliminate some of these barriers to care. So again, by way of background, the main reason that we're trying to address this issue is that, of course, there's going to be, and there already has been, an increase in these end-stage liver-related diseases, including cirrhosis, hepatocellular carcinoma, decompensation, and liver-related deaths. These are projected increases from 2000 to 2020. And this comes from the clinical case registry at our VA, looking at 3 fiscal years up through 2006. And as you can see, the trend of the number of cirrhotics in this clinical case registry of about 215 to 220,000 people in the VA system. You can see that the cirrhosis in the blue boxes has increased over time, and not surprisingly, the number of hepatocellular carcinoma cases has increased as well. So evidence that these projections are already coming to fruition down the road. This is also transplants within the VA. Now, we don't transplant a lot of folks, and a lot of folks veterans who are seen in our system are transplanted elsewhere. And the fiscal year 07 is a partial portion of that year. But as you can see, the number of transplants is going up. Again, the number of people referred for transplantation is going up. And the reason I bring this up again is that, if we think about, and I'll present some evidence to support this, is that psychiatric and substance use disorders are bigger barriers to antiviral treatment than most other things, depending upon the study you look at. And so this is going to be a struggle, I think, as not only now because of the current antiviral treatment rates are quite low, but as we get more and newer treatments, we're going to be faced with more people wanting treatment and more people hopefully being eligible for treatment. And I think the next speaker is going to be speaking to, hopefully, that things are going to be coming down the pike soon. But this also gives you a sense for, if we do nothing, the impact of the future of end-stage liver disease will be impacted at various levels depending upon the number of patients we can treat. And again, psychiatric and substance use disorders tend to be the most common reasons for exclusion from hepatitis C treatment. So again, this is nothing new, but psychiatric disorders are, at least among veterans, and outside of veteran care are common among patients with hepatitis C. And this was a study done, a large database study out of the VA system, again, comparing 33,000 hospitalized hepatitis C patients who were identified after 1992, looking at their psychiatric and substance use disorders, and then comparing them to random non-Hep C controls. And again, not surprisingly, 86% or so of those patients had at least one past or present psychiatric and drug and alcohol use related disorder. And surprisingly, 29%, close to 29% had an active substance use disorder. And by active, they meant being hospitalized in the past year. So that meets a pretty stringent threshold for an active use disorder, since most of the care is becoming outpatient at this point. So, and not surprisingly, again, Hep C cases were much more likely to have alcohol and drug use disorders. Seen from a different perspective, as you all are aware, hepatitis C is common in patients who are in areas where there are likely to be substance use and psychiatric problems: incarcerated individuals, HIV-infected individuals, IV drug users, and veterans in the United States. So hepatitis C is common. It's got a little skewed here. There are a number of studies, and I'm not going to go through them each individually because there are just too many of them, but I think it proves a point a little bit about how these common psychiatric and substance use disorders have been used as are exclusionary for antiviral treatment. And as you can see here, these are various studies across the columns here, usually reasonably small n's, but combined, I think they tell a pretty striking story of how, I suppose you could call these patient factors, do impact whether patients get treated or not, ranging from, as you can see, a low of 7% to as high as 77% of patients being excluded for antiviral treatment. Now, these are all VA studies. Again, more VA studies, more recent studies, but a high number of patients who have both psychiatric and substance use disorders being excluded from antiviral treatment. It's more than those excluded for medical reasons in most of these studies. And just in general, how many people are getting excluded from treatment? 83%, 75%, a very large patient population who don't meet criteria for treatment. Now, the VA is a special group of people. They tend to be seen as having higher rates of psychiatric and substance use disorders. And so I did want to present some of the reasons for exclusion from antiviral treatment, at least mostly in the United States. But again, even in the community, psychiatric and substance use disorders are common reasons to exclude from treatment. Now, there are other, I'm calling these patient factors. I suppose you could look at them as more interactional factors between patients and clinicians. But certainly there are a number of other studies looking at patient-level factors, and I think we've heard some issues related to stigma. Clearly, substance use and alcohol use is a stigmatized population. Hep C patients are stigmatized and may not seek care due to those reasons. They have other, psychiatric populations may have other reasons to not seek care as well. So, I've been actually looking through a bunch of our charts recently, interested in stimulant users, and a lot of people, wind up getting hospitalized psychiatrically and dropping out of care, become homeless. And so there are a variety of other patient-level reasons for not getting into care and not seeking care.